Okay, good afternoon, everyone. My name is Ann Wong with the Illinois Chapter American Academy of Pediatrics, and I thank you for joining us for today's webinar on the business side of vaccines, coding for immunization services. Today, we are joined by Becky Nolan from the American Academy of Pediatrics. Before we begin, I would like to go over a few housekeeping items. Participant phone lines are muted. This webinar is being recorded. Everyone will receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar by end of business day. If you have any questions for Ms. Nolan during the presentation, please enter them into the question box on your control panel for the webinar on the right-hand side of your screen, and Ms. Nolan will answer them at the end of the presentation. I would now like to introduce Ms. Nolan. She holds a master's from Tulane University, and she has spent over 10 years at the American Academy of Pediatrics working in the Division of Healthcare Financing on coding, private payer, and Medicaid issues, as well as coding education and ICD-10-CM issues. She is a certified professional coder and a certified pediatric coder through the American Academy of Professional Coders. Prior to starting her work with the AAP, she spent over 10 years working in a private pediatric office where she worked in the front office coding and billing and also as a part of the clinical staff. Please join me in welcoming Ms. Nolan. All right, I'm gonna turn it over to you now. And then all right, Becky, I'm trying.
Thank you.
Yeah, let me just give me 1 second. I'm trying to make you the presenter right now.
Okay.
All right, Becky, you should be able to set it. Perfect.
All right, sounds good. Well, thank you very much for that introduction, and welcome everyone to today's coding webinar on coding for immunization services. Of course, I have no faculty disclosure information to share. I will not be discussing anything that I shouldn't be. So we can't talk about vaccines unless we talk about the dreaded question we hear every time we walk into an exam room with those vaccines. This won't hurt, will it? Well, we'll try to make it hurt a little less. So today we're going to be discussing both the CPT and ICD-10-CM coding for vaccines and the importance of it. And we use CPT and ICD-10 in this country for payment purposes, which is something most countries don't do, especially for the ICD side. And it allows for increased and appropriate payment when we're using our proper codes. It also decreases our liability by relaying the proper information, and it improves information flow. So it stops payers from coming back to us and asking a lot of questions if we send in our claims with the appropriate information and the full scope of the information that we need to relate to our payers. So we're going to start out with my favorite topic because it's the one I work on the most. It's ICD-10. So as you know, we've now moved well beyond I-9. We're well into the I-10 world, and we only have one ICD-10 code we need to use to talk about why a patient came in for vaccines, and that code is Z23. It's required to be reported in addition to well-child checks, which is something new that we didn't do in I-9. And we also have a whole slew of codes to tell us why a vaccine was not given, which does parallel to what we had back in ICD-9 with some variations. Again, as I mentioned, we're going to report Z23 for every vaccine encounter. And we also have a new code coming out on October 1 for why a vaccine was not given, and this will be discussed later on in the presentation. So let's look at our ICD-10 coding. A 9-year-old presents to their pediatrician with a foreign body in their right thumb. During the encounter, the pediatrician determines they also need their flu vaccine. The physician counsels, and the vaccine is given. So our primary code is going to be for the reason they came in, the superficial foreign body, but we're also going to use our Z23 to note the patient also had an encounter for immunizations. Now, while the CPT code will also tell us that, they do want to see that ICD-10 code linked to the CPT codes for the product and or administration. Now let's look at another one. A 4-month-old presents for their well child check. The baby is healthy. Vaccines are ordered and given. Our primary code is going to be our Z00.129. So that's our routine well child exam without abnormal findings. And in addition to that, we also need to link it with our Z23. So both codes need to be on the encounter form. So while I love ICD, it's pretty short and sweet for this. So we're going to move on now to the CPT side. First up, we're going to discuss immunization administration. We haven't had a change in immunization administration codes in quite some time yet. This is still an issue that gets brought up a lot on the AAP's coding hotline, which is where we take a lot of the questions from members and their practices. So as you know, we have 2 pediatric immunization administration codes, and we call them that because they're age-based. So this is immunization, the 90460, is the immunization administration through 18 years of age. So that includes everybody who's currently 18 years via any route of administration. We don't care if it's oral, intranasal, or injectable. But this does require counseling by the physician or another qualified healthcare professional and is reported for first or only component of the vaccine. 90461 is our add-on code, which is why it has a plus sign in front of it. And this describes the services for each additional component that is part of the initial vaccine that is also being counseled on. We get asked still to this day, what is another qualified healthcare professional? And really, in a nutshell, it's a provider that can bill under their own NPI. They don't work under the supervision of another provider. So that's typically physicians, it's nurse practitioners, it's physician assistants. And those vary from clinical staff. And clinical staff is someone who works under the supervision of a physician or another qualified healthcare professional who may be allowed by law, regulation, or the policy within the facility they work to perform or assist in the performance of a certain service. So this is typically your nurses, your registered nurses, your MAs, your CNAs. They are considered clinical staff. So they do not fall under the definition of another qualified healthcare professional, which is defined in the CPT manual. Another question that we still get is what's a component? So a component refers to each antigen in a vaccine that prevents a disease caused by a single organism. Conjugates or adjuvants contained in vaccines are not considered to be components. So let's take a look at what that looks like. So HPV has one component. That is reported with CPT code 90460 when that vaccine has also been counseled on. Versus a TD, which has tetanus and diphtheria. That's considered a 2-component vaccine. So we have our 90460 and our 90461 so long as we have documented counseling. Now the pneumococcal we know is a 13-valent. So that still is, though, a single organism. It's still just the pneumococcal. So that'll only be a 1-component vaccine with a 90460. So sometimes it's best, depending on how you think of things, to think of this more as a flow. So if we're looking at which vaccine administration to code for that day for a certain patient, we ask ourselves, is the patient 18 years of age or younger? The answer is no. We have our answer, 90471 through 74, which we will talk about. The answer is yes. we have to move on to our next question. Do we have documented physician or other qualified healthcare professional counseling? The answer is yes. We got at our 904-6061. We can use those codes. If the answer results in a no, we're back to the 7-1 through 7-4 codes, which we will talk about. So remember, if both the criteria for reporting 904-6061 are not met, meaning patient is 19 years of age or older, or physician or other qualified healthcare professional does not counsel, then we defer to our other set of codes. And those we just refer to more as our non-age specific immunization codes. It doesn't mean you can't report them for a 4-year-old or a 5-year-old. It just means that these are non-age specific. If our criteria is not being met, meaning both the age and the counseling are not met, we defer to these codes. So they're not stuck to a certain age category. Now these codes are set up very differently than our other codes. The 90471 is the immunization administration for a single vaccine, one vaccine. 90472 is each additional vaccine. These are both for injectables. Versus our 90473 and 74, again, they are per vaccine. 90473 and 74 are our intranasal or oral vaccines only. And again, these are not based on components. These are based on per vaccine. Now remember, the 90472 and the 74 had the plus sign in front of them, meaning they are add-on codes. So 90472, which is our add-on for an injectable, could only be reported in addition to a 90471 or 90473. The 90474 is reported in addition to 90471 or 90473. You will never report two initial codes together, meaning you will never report the 90471, which is our initial injection, and your 90473, which is your initial oral or intranasal, together. So in looking between the two and when to decide when to use which category of codes, remember your 904-6061 requires counseling. It's reported per component and has a specific age requirement, 18 years or younger. The 90471 is reported based on route of administration, which we've already talked about, the intranasal, oral versus the injectable, and reported per vaccine, not per component. So even if it's a DTaP, if it's an MMRV, doesn't matter. It's one code for that entire vaccine when we're reporting our 90471 through 90474 series. We're often asked what needs to be documented for the counseling aspect for 904-6061. CPT does not give us clear guidance in this way. So we offer up some suggestions that should be documented when there's physician or other qualified healthcare professional counseling. They must document on all the components that they did counsel on. Documentation should always reflect what's done, and that's for any service we provide. And that includes the guardian or patient receipt of the VIS, the vaccine information sheet, the risks and benefits of the vaccine components, issues or concerns that were brought up by the parent or guardian, and a care plan over the next few days to deal with possible side effects of each component and when to call the office. Now, again, these are just guidances. They are not official documentation guidelines, but they're ways to be able to prove to the auditor that, yes, indeed, we provided appropriate counseling for each component. Now, if your physician or other qualified healthcare professional does not counsel on all vaccines given on a certain day, then you cannot report the 6061 for all of them, which is why it's important to document everything you counseled on. You only report for the 60 and 61 for those that are counseled on, and there's documentation to prove it. For those vaccines not counseled on, we have to defer back to our 90471 through 74 series. But CPT guidelines do state that you will always report the 90472 or 74, which is our additional injection, 72, additional oral or intranasal under the 7.4 if you are already going to be billing your 90460. So for example, your physician counsels a mom on the MMR, but not the annual influenza. You will report the 90460 and 90461 with 2 units for your MMR because it was counseled. Then you will report your 90472 for the influenza. You gave an injectable for the influenza, but there's no documented counseling. So you will report the 7.2, not a 90460 for that vaccine. And remember, it will be the additional vaccine code. So the 7.2, not the 7.1. Another issue that comes up quite a bit is what do you do when you counsel, but parents don't want it? You can't report the counseling IA codes if vaccines are not given on the same day. It's a 2-for-1. You have to have both in order to report the code. The vaccine counseling will then simply fall under your preventive medicine service code if the patient's there for a well check, because there's no other way to capture vaccine counseling if you're providing a preventive medicine service for that day. It seems odd to be talking about this, but I do want to mention when not to report IA codes because these questions also come in. Immune globulins. Those are also located in the same area as the vaccine products, but they are not considered vaccines. So the RSV is probably the biggest one we see in pediatrics, also the rabies immunoglobulin. You will not report vaccine administration codes with immune globulins. You will always report the 96372 admin code. That's the same administration code you use for antibiotic injections as well. But you will not report vaccine administration codes. In addition, the PPD test, this is not a vaccine or a toxoid, and in fact, the 86580, when it was valued, already takes into account the administration. So there is no separate administration code for your PPD. Shifting gears a little bit and staying on the CPT side, we're going to talk about vaccine products. So as you know, when you give a vaccine, especially in the private payer world, you have to report 2 codes to show the service. You have to show the product and the administration. So we've already talked about the administration side. We're going to move on to the products. As most of you know, they are found in the medicine section of the CPT manual, which is at the end of the manual. It identifies the specific vaccine product only. Again, this has nothing to do with the administration. And some common codes. Some of you might even know these. I still remember the DTAP, the 90700. The Pediatrics 90723, varicella 90716, and the Hep B 90744. Vaccine product codes are released twice annually, which is different from all the other CPT codes, and that is due to the fact that products are coming out throughout the year, and we need to be able to report them once they become available on the market. They are on the AMA, the American Medical Association website, as AMA owns CPT. So codes that are posted on January 1st become effective the following July 1st. And codes posted on July 1st, so the ones that were just posted on July 1st, 2018, will become effective January 1st, 2019. If you see a vaccine product code with a little lightning bolt next to it, that indicates the vaccine is still pending FDA approval and will most likely not be reportable to a payer. The site listed here is one you can bookmark because it's where you can go to find the vaccine updates that do occur twice annually. Now remember, when you're reporting your vaccine product code, that you must report the code that most accurately identifies the vaccine you're administering. There are many different variations now, especially with more and more products coming on the market. You have to look at the product itself. Is it a combination or is it a single component? What disease is being targeted? For example, Hep B. The dosing schedule, sometimes that varies even in the same product line. Is it a 2-dose or a 3-dose? age indicators, chemical formulations, route of administrations, and whether it contains a preservative or no preservative, which, as most of you know, is most important for our influenza vaccines. Now remember, now that we are combining more and more vaccines, that you are reporting the product code that reflects the combination. So if you're administering a vaccine product that contains a combination of vaccines, for example, your DTA, PIPV, Hib combo, you must report the appropriate combination vaccine product code. So in this case, the 90698. It is not appropriate to separately report each component of the vaccine with their individual product code. You would not report a code for the DTAP, a code for IPV, and a code for Hib. So we don't have too many updates for the 18-19 coming year, but there are a few. This is just a reminder, we mentioned the FDA approval pending the lightning bolt. If you see a dot in front of a code that's changed, that's a new code. Triangle means it's been revised, and the hashtag simply means it's been resequenced. So for those of you in a multi-specialty clinic, you might be administering the zoster or the shingles vaccine. So we do have FDA approval now for a new one on the market. In addition, we do have a new hepatitis B FDA approval for the adult dose, 2-dose schedule for IM use. And that's being used for 19 years and older, I believe, which you still may see in your practices. So that's both of these codes are now FDA approved. They're on the market, and the CPT codes have been updated to reflect that they're FDA approved. Now, the 90750, as you can see with the dot, is a brand new code, while the 90739 has been in the CPT manual for quite some time. You will see these codes without the lightning bolt in CPT 2019. Another new code, it's an influenza code, 90689. It's the influenza virus vaccine quadrivalent, an inactive preservative-free. It was released on the AMA website July 1st. The effective date is January 1st, 2019, like we just spoke about, and will appear in CPT 2019. This was a product that was going to be available for this year, but we just received word from the manufacturer it will most likely not be available, so we won't have any issues, hopefully, with being able to report this code prior to the implementation date of January 1, because as you know, flu season will be here before that. So in continuing with our influenza vaccines, most of us are gearing up for ordering, if we haven't already ordered our flu vaccines for the coming year. Feels like we just ended the last year's flu season, and here we are again. So it's important for the 18-19 flu season that we pay attention to the fact that there still be some quadrivalent, or excuse me, some trivalent, mostly quadrivalent. There will be much more, less products on the market this year in the trivalent world, but there's still a few, again, which is very important when you're reporting the product code to ensure that you're using the appropriate quadrivalent if it's a quadrivalent versus the trivalent. There's so many different variations within the influenza products, not just for the 18-19 season, but for the last several years. But always ask yourself to be sure you're in the right code. What's the route of administration? Are we in the one, if it's an IM, are we using an IM code? If it's an intradermal, are we in the intradermal code? Is it a trivalent or quadrivalent? Preservative, no preservative. Is it antibiotic free? Dosage recommendations. So these are all the important things to take a look at to ensure that you are getting to the right CPT product code for our influenza. I will not go through this, but this is just a reference for you for all the known vaccines that are going to be on the market for this year's flu season, their manufacturer, what CPT's descriptor they go with, their recommended age, and then of course their corresponding CPT code. This was as updated as of July 1, so hopefully not much has changed, but you know there are always things that kind of influx on the market that we may not be aware of. But this was pretty updated as of July 1st, so you should be good with this list. So the 2018-2019 influenza recommendations are out there. So on February 21st, the ACIP, which is the Advisory Committee for Immunization Practices, that is a Centers for Disease Control group, recommended that the live intranasal, the LAIV4, be an option for influenza vaccination of persons for whom it is appropriate for the 18-19 season. So basically what we want to say is welcome back flu mist. We haven't seen it in a couple of years, but it's back and it's being approved by ACIP, which means payer coverage. So for the 18-19 influenza season, they are allowing providers to choose really any licensed age-appropriate vaccine out there, including the LAIV, which is what the recommendations say. So that, again, that translates to payer coverage. So no preference has been expressed for any influenza product. And that leads us very nicely into our product coverage conversation. Remember, without FDA approval and the CDC's ACIP, which we just mentioned, AAFP or AAP routine recommendations, a vaccine will not be covered by most, if not all, payers. So that is why I mentioned with the LAIV now being on the routine recommendation, most payers will be covering it now. So it's back, it's back. So for more information, always refer to the CDC ACIP website, which is listed here, or the AAP's website. Coverage is very much dependent on this information. So payer coverage policies for vaccines may depend on, or typically do depend on, ACIP recommendations like we just mentioned. And those recommendations are published in the MMWR, which is the Morbidity and Mortality Weekly Report, I believe it stands for. Or it'll be based on recommendations by the American Academy of Pediatrics, which usually follow ACIP, but they can vary. Never blindly follow manufacturers' recommendations. They do differ, and they may differ from ACIP recommendations. So it's very important to not blindly follow manufacturer recommendations. Recommendations always follow FDA approval, so be sure that once a vaccine's been approved, that it also comes with a recommendation from ACIP or AAP, because sometimes there's a lag time between the two. And remember that if you are routinely vaccinating, meaning this is just something you're going to do for all your patients, not just those who are traveling to endemic areas or may be immunocompromised, be sure that you are following the routine recommendations within the ACIP or AAP recommendations. Those are found within that article I mentioned that is posted in the Morbidity and Mortality Weekly Report, the MMWR, which are always found online at that website through the CDC ACIP. You're going to look for the section marked recommendations. That's where you're going to find all the information you need to make an educated decision on when to be vaccinating your patients and if they are routine recommendations. So in a nutshell, vaccine product coverage, FDA approved, published ACIP AAP recommendations. Are you giving it in compliance with FDA approval and ACIP and AAP recommendations? If you are, your answer is going to be yes. This will more than likely be a covered vaccine. These are a couple of new ACIP recommendations. I won't really go into them too much, but if you want to take a look at them, one is based on the new hepatitis vaccine that we talked about earlier, the new FDA approved, so they did add it to the recommendations. So again, now we've got the FDA approval. On February 21st, they gave a go-ahead for the recommendation, so that vaccine will most likely be covered by most plans that have vaccine coverage. The second one is an ACIP recommended of a third dose of the MMR for those patients who are identified in an area with a public health outbreak. So in a public health crisis area where they have an outbreak of the mumps. So that again, if you have a patient who's in that area and you need to be able to give a third one because it's routinely recommended by ACIP, the vaccine should be covered. So that's great, we know how to report it. Now we need to make sure we're getting paid. So payment for vaccine products is a very intricate issue. So payment for the product should always take into account, this is when you're being paid for by the payer, payment for the product itself. So flat out, what you have to pay for it should be part of that, of course. But there's so much more that goes into it. The personnel costs for ordering an inventory, your storage costs, insurance against the loss of a vaccine, recovery of costs attributed to inventory shrinkage, wastage, and non-payment. This is where a patient refusal that happens after a vaccine is withdrawn, and now you've got to throw it out because you were not able to give it within a certain amount of time. And lost opportunity costs. So the cost of maintaining a very large vaccine inventory, these vaccines are not cheap. So you should be compensated for having to hold on to all of these vaccines. In addition, payments for vaccine products must be free of any discounts and based on a transparent and verifiable data source, such as the CDC vaccine price list for the private sector. On the previous slide, there is a list, there's a website that I listed for the CDC private sector cost for vaccines, and most of those vaccines actually fall on the VFC list. Cover the vaccine product purchase price as well as all related office expenses that we noted on the last slide, and a return on investment for the dollars invested in your vaccine inventory, and be at least 125% of the current CDC vaccine price for the private sector. Again, I would defer you to the website from the CDC on the previous slide. That website there will list all the prices for the private sector, and your payment should be at least 125% of that. Now, if you find that your vaccine product payment rates are below this, be sure to read your contracts with the payers. Make sure there's nothing in the contract that is now precluding you from getting appropriate payment. Make sure they are paying what was negotiated in your contract. So if it is below what you've negotiated, make sure that you talk with your payers about that. Remind the payer that these indirect costs that we referred to, the ordering, et cetera, are not taken into account with the vaccine administration codes. Some payers like to think that's the case, but vaccine administration services have their own work and issues built into that in time. This has nothing to do with the product. Now, we have this issue more and more, vaccines not being given during encounters. In ICD-10, we do contain codes that allow the physician to report vaccinations that have not been administered. We do report as a secondary diagnosis code. And unfortunately, they are not specific to show which vaccine was not given. We don't have that capabilities. So if you look in here, we do have vaccinations not carried out due to, we have an acute illness, allergies to the vaccine or the components. We've got the refusal codes, whether it's the caregiver or the patient. Patient already had the disease, other reasons. Now we've got a new code though for this year, and that's the unavailability of the vaccine. And this is extremely important, especially when there is a manufacturer shortage. This is a great way to be able to internally track those patients that you may need to call back in once the vaccine is available on the market. So anytime we see a vaccine shortage based on a manufacturer, you use this code obviously to show the payer, but then you can also run reports later on once that vaccine's available to be able to say, okay, here are the 30 patients we need to call back in because our Hib is now in stock or the HPV is in stock or whatever vaccine is unavailable at that time due to manufacturer issues, product issues, or there's a delay. So it's really great opportunity to capture those patients as well. And that will be effective October 1, 2018, when the new ICD-10 CM codes become effective. So let's look at an example. A 12-month-old patient presents for a well child exam and vaccines. The patient contracted the chickenpox at 10 months of age. Patient receives the Hep A and MMR, but not the varicella. So you would have your 99392, so your preventive medicine service, and you would link it to your Z00.129 routine well check. You'd also link it to your Z23 because the patient had vaccines. And then you'd also link it to Z28.81, indicating that a vaccination was not carried out because the patient already had the disease. Now, again, we talked about the fact that we can't say which vaccine was linked to, but hopefully the payers through their system can also figure that out as well based on what was recommended at the time and what was given. But at this point, we do not have that capabilities. And as far as I'm aware, we're not looking to take it that further on the ICD-10 side. I don't know if they're going to do something on the quality measure side, but at this point, ICD-10 isn't looking into that. All right, another scenario here. A 13-month-old patient presents for their routine well child exam. The parent is informed the child will need her MMR and varicella. The mom refuses, stating she believes both vaccines are harmful and would like her child to be older. Despite counseling the mom about the vaccines, she still refuses. So again, we have our 99392. We're going to link that to Z00129. Our encounter for immunizations, because that's why she's also there. And then our Z28.82 for vaccinations not carried out because of caregiver refusal. Now, remember, we spoke about this earlier too. You can't report anything separate for the counseling in this case on the CPT side, because there's nothing that we can report because they consider vaccine counseling to fall under the preventive medicine service codes. So again, there's no way to know which particular vaccine, and their concern with that is the HPV, because that is being monitored on HEDIS. So how do we show that we as the practice did our due diligence, we tried to give the vaccines, we did our best, parent or patient refused, and that's their right, so here you go. But that should not hit our HEDIS measures because you did attempt and try to give that vaccine. So at this point, we have no way to remedy that. And again, I'm not sure if they're going to attack this from the quality front. So vaccines are drawn up and not given. Very common. We hear about this a lot on the hotline. A patient or parent is told what they need. They are counseled. They have agreed to get the recommended vaccines. And after the vaccines are drawn up, brought in the room, they then refuse. What are your options? Are you simply out the money now if you're not able to give it later on in that day? So we got to prepare for these situations in advance. Look at your payer contracts. You may need to contact legal counsel about drafting an office policy that makes the parent or patient responsible for any of these costs, and also learn your coding options and what you can do to possibly get the money for these vaccines that are now wasted. Again, keep in mind that the AAP does fight for vaccine product payment above and beyond costs to ensure that you are paid for some of this wastage through other vaccines. Some payers allow for payment when the product code is submitted with the JW modifier. Another ICD code that you can use is the under immunization status. That's the Z28.3. It's the under immunization status, delinquent immunization status, or elapsed immunization schedule status. And you use this code as appropriate when a patient comes in for any encounter, really. If you want to say the patient was in for some other unrelated condition and you offered vaccines and they refused, you can also continue to use this code to denote that they are under immunized. So immunizations and your E&M services or your office visit services. When can you report the two together? So if a significant separately identifiable E&M service, for example, your office-based E&M service, they're here for a sick visit, a preventive medicine service, or some other outpatient visit is performed, the appropriate E&M service code should be reported in addition to the vaccine administration code. Modifier 25 will be required when reporting a problem-focused E&M service. And in addition, modifier 25 is now required, I think, for most payers when you're also doing a preventive medicine service. The 25 would go on your preventive medicine service. But you have to keep in mind the rules for using modifier 25. Modifier 25 is defined as a significant and separately identifiable E&M service by the same physician on the same day of the procedure or other service. Service should be above and beyond the other service provided and substantiated by documentation, should be medically indicated and necessary. When patients come in for vaccine-only encounters, however, it's very important to determine really, is the E&M separate or is it part of the procedure they came in for? The patient presents for a sole purpose of vaccines, which is very common in flu season and is also common when a patient may need like a second or third in a series, especially with the HPV. If the vaccine is the only thing that is addressed and nothing else is brought up, you only code for the vaccine administration and the vaccine product. Do not report a separate E&M service for vaccine-only visits unless the service does meet the criteria for using modifier 25. We're often asked a lot about 99211 because a lot of these vaccine encounters are nurse-only visits. The 211 is the lowest level E&M service. It's considered our nurse-only visit. When a patient sees the nurse for immunizations only, you will not report a 211 in addition, a 99211. You may, if there's a significant and separately identifiable and medically necessary service, if you refer to modifier 25, but a lot of times if that happens, the doctor would probably have to intervene if there was something really going on with the patient. However, we have one exception, and that's Illinois Medicaid. Illinois Medicaid does take exception to this. Under Illinois Medicaid, it states that reimbursement for the practice expense of administering the injection is included in the office visit when the client sees the practitioner. If the client comes in solely for the injection, the CPT code for a minimal level office visit for the not requiring the presence of a physician, may be submitted to cover the practice expense, and the specific vaccine procedure code is to be submitted to cover the cost of the vaccine or the cost of obtaining it through VFC. Seasonal flu vaccinations follow these guidelines. So Illinois Medicaid basically says if they are coming in for a nurse-only visit, let's say to get their flu shot, you may report the 99211 and in addition to the product code to be reimbursed for the administration. So speaking of Illinois Medicaid and VFC, we're going to talk a little bit about that. In Illinois, children through 18 years of age who meet at least one of the following criteria, meaning they have Title 19 Medicaid eligibility, they are not insured, meaning a child who has no health insurance, they are American Indian or Alaska Native, as defined by the Indian Healthcare Improvement Act. They are underinsured, which is a bit of a caveat. It's a child who may have commercial insurance, but the coverage does not include vaccines, or a child whose insurance only includes some vaccines. Once that coverage is reached, so once they've reached their max benefits for vaccines, the child is then categorized as underinsured. Underinsured children are eligible to receive VFC vaccines only, however, through a FQHC or a rural health clinic or a deputized local health department. So they're allowed to have VFC, but most of your practices will not be able to give them if they are not a VFC or rural health, a FQHC or a rural health clinic. So as of 2016, the following people will not qualify. So children up to age 18 with Title 21 eligibility, children up to age 18 with state-funded eligibility, and participants 19 years and older, regardless of title. So this just kind of breaks down, gives a chart of the two side by side. You can take a look at that. I don't want to go into that. But again, for the underinsured, they will hit both the private stock up until their benefits, and then of course with the caveat that they can receive VFC stock under certain circumstances. So what happens if you do have an underinsured patient who presents to your office for vaccines? They've maxed out their benefits and now you have to refer them. The Illinois VFC site does have a resource for this. On this page is the the link that I will provide to you that you can take a look at after the webinar. And they have a search feature. And I just pulled up just a screenshot of what that looks like. So what that looks like is all the places in the local area that you can get VFC vaccine. So if you're a VFC provider, you're going to probably show up on this list. But it also lists places where people with CHIP can get vaccines, possibly through the VFC, because there are certain practices that are allowed to do this. So if you take a look at this site, this will help you refer any patients that you have who fall under that underinsured category if you are not allowed within your practice to administer those vaccines. And once again, the link is on the previous slide. So continuing on with the VFC in Illinois Medicaid, modifier SL. So this is reported with a vaccine when the vaccine is state supplied. And it appears that in Illinois Medicaid does require this for the HPV vaccine if the provider is not enrolled as a VFC provider. So this might be an OBGYN office. So again, if you bill multi-specialty, I know there's not a lot of OBGYNs on this, but if you bill a multi-specialty clinic and you have a patient present who is VFC eligible and they receive an HPV through your practice, you can bill for the vaccine with the SL modifier, and you will be paid for the cost of the vaccine. So as we wind down here, we're going to look at some coding options. This is specifically related to our vaccine administration services. This is just to kind of refresh everything that we talked about early in the presentation about the administration side. So let's look at our first scenario. The patient or parent is counseled by a physician or a qualified healthcare professional on a single component vaccine. Vaccine is given. The patient is 19 years old. So what's our administration code? In this case, it's a 90471 if it's an injection. And then of course, now that we've brought back our intranasal of FluMist, it could be a 90473 depending on the vaccine given. Look at the next scenario. We got a patient or a parent that is counseled by a physician or qualified healthcare professional on one multiple component vaccine. The physician or qualified healthcare professional gives the vaccine. Patient is 19 years old. We have a 90471. The patient is 19 years old, so we already have the 9046061 completely off the table. So we have to always defer to our 90471 through 74 codes. And remember that our 90471 through 74 do not take into account additional components. Let's look at our next one. The patient or parent are not counseled on two multi-component vaccines. Both are injectables. The patient is 5 years old. We're going to report our 90471 for the first and 90472 for the second vaccine. Even though the patient meets the age requirement, counseling is not done. So again, 90460 is off the table, and our 9047172 are not reported based on components. Patient and parent are counseled by the nurse on two multiple component vaccines. Both are injectables. Patient is 5 years old. We're reporting our 90471 and 90472. Again, even though the patient meets the age requirement, the vaccine counseling is done by clinical staff, the nurse, and therefore does not meet the other qualified healthcare professional requirement. So a patient or parent are counseled on two vaccines as part of a well-child check. Because the patient is sick, however, the physician has them return in 2 weeks for shots only. When they return, the patient only sees a nurse. What codes are reported for the counseling? None. Unfortunately, we are not able to capture that as part of the well-child check, which we've already talked about. And what codes are reported for the administration upon their return? The 90471 through 74, again, because we are not able to count the vaccine counseling that took place previous, and this is a nurse-only visit, so we are stuck with our 90471 through 74 codes. Next one is the patient or parent is counseled on a 3-component vaccine. Given that same day are 2 other single-component vaccines where no counseling is documented. The patient is 12 years old. So for our 3-component vaccine, you're going to see the 90460 and 90461 with 2 units. And you're going to report your 90472 with 2 units, or by line item with 2, because they also had 2 other vaccines given where there was no documented counseling. But let's look at some vignettes for Illinois Medicaid, because as you know, it's different. So let's look at the first one here. An established patient presents for her 13-year-old well adolescent check. She has never received her HPV. The physician counsels and asks the nurse to administer. What is reported for the entire encounter? So of course, we're going to have our 99394 for our preventive medicine. And then because this is the HPV, you're going to report the 90649 SL. Same patient returns 6 weeks later for the second Gardasil. She sees a nurse only, or she might even see a physician for the injection. Based on Illinois Medicaid rules, you can report the 99211 for the minimal office visit in addition to the 90649 with the SL modifier. That is an Illinois Medicaid rule only. So we're going to look at a few other just vignettes overall. For a 2-month-old check, we have an established patient that presents for her checkup. Patient is healthy, normally developing. A full preventive service is done. And following the periodicity schedule, the following is ordered. So we have a maternal depression screen and immunizations for age. So our Pentacell, our Hep B, pneumococcal, and rotavirus. So this is how the coding is going to pretty much lay out. You're going to use your modifier 25 on your preventive medicine service. You're going to report modifier 59 on your 96161 for the maternal depression screen, and that is because there is an edit on the 96161 and 90460. So if there's not a 59 modifier, it may deny as bundled. You report the 90460 with 4 units and your 90461 with 4 units. You've given 4 different injections and you have 4 additional components with the Pentacell. Let's look at our 13-year-old. An established patient presents for her annual check. A preventive medicine service is performed. The patient is behind on vaccines and they are updated. The following is ordered per the periodicity schedule. We have our hearing screen, depression screen, the Kraft screen, as well as our HPV, Tdap, and meningococcal. So again, we're going to look at this and see that they've been behind on vaccines. There's counseling that was done as part of, that's with the Z68 and Z71 as part of our quality measures. We have 99394 for their well check, their 92551, the 96127, the 96160 with the 59 modifier, because there was, again, the edit. And then you have your list of your HPV, your Tdap, meningococcal, and all of your vaccines on the administration part. So your 90460 with 3 units, because 3 vaccines were given, and the 90461 with 2 additional units for the Tdap, the additional components there. And I think this is our last one. So a 17-year-old presents for his checkup. He has chronic asthma, but has not been checked up in over a year. History reviews some flare-ups. A spirometry is done, an asthma control test completed, and new medication prescribed. BMI is slightly elevated, but overall patient is healthy. So we're going to order the following: the dyslipidemia screen, the lab, and that's outside, the depression screen, the Kraft screen, and our immunizations, the meningococcal, and they are up to date on all the others. So this is again how it's going to look with all the modifier placements. And I'll let you review that as we're running up on the hour here. So these last few slides here are just some resources from the Academy. I didn't review NDC codes this time, but there are resources at the end of this. When you get the slide presentation tomorrow, there'll be more information on NDC codes. This is the link to for billing Illinois Medicaid for vaccines and where to refer which section and appendix. Some AAP resources that we have on vaccines at the national site. Again, some payer resources. We discussed the business case for pricing vaccines. We also have one for pricing immunization administration, and the vaccine addendum to payer contracts. That does require AAP login if you're an AAP member, and there's the link to that. And again, the rest of these are just resources for you to take a look at after the presentation. And that concludes it for today. Thank you, and please submit your questions.
Okay, thanks, Becky. So taking a look at the question panel, and I don't see any at the moment. So while I wait for people to enter in their questions, I'm going to go ahead and just kind of finish wrapping up everything so you know what your next steps are. Okay, so we do have another upcoming webinar. I'm sorry, I forgot to change the date on that. It's August 29th. It's a Wednesday, but it is going to be on meningitis, and you can register at that link below. So what next? This is kind of just a reiteration of what I said earlier. Everyone's going to receive a copy of the PowerPoint slides, a link to complete the evaluation, and a link to the recording of the webinar. But everyone must complete their evaluation by August 3rd, 2018. And after that date, the evaluation will be closed, and you'll no longer be allowed to fill out the evaluation or receive a certificate of attendance and or continuing education credit. You will receive your certificate by August 17th, 2018. So I still don't see any questions at the moment. So I'm gonna give it like a little bit longer, but otherwise it does then look like, you know, everyone seems to be good. Let's see, Becky, is there anything else that you want to add at all during this time?
Just a reminder that the National AAP is there for any coding and payer issues, even if they're not vaccine related. We have staff on hand that work very closely with private payers, and we work very closely with obviously the Illinois chapter and Medicaid issues. So feel free to reach out to us if there's anything that comes up, even if it's not vaccine related.
Oh, so I do have one question from someone. The question is, as a health department without a physician, are the staff nurses considered OQHCPs?
No.
Okay.
They are not. No, they're not, unfortunately. And you know, with being in the health departments, I'm sure you see a lot of VFC patients as well, so it won't even matter for you in terms of the difference between the administration. But if you do see private payers, no, unfortunately, the CPT definition has really put us kind of in a bind there.
Yeah. Okay, I think that about wraps it up then. And as Becky said, if anyone does have any additional questions, feel free to reach out to the AAP, or you can contact me directly over at ICAP, and I'll be sure to get it over to Becky. So thanks so much, Becky. As usual, it's always incredibly informative. You know, it's a confusing world, so it's nice that we have you here to help us out.
You're welcome. Happy to do it.
Thank you so much. Everyone have a great afternoon.
Bye-bye.
Bye.